everyone. I had a very short break, so I wanted to talk about 5 ECGs that kill patients while everyone is looking for a STEMI. I want to start with most doctors. Hello. So I'm just going through a few dangerous ECGs. I have a short break, and I just wanted to start, to do a short live session. I've never gone on live. This is my very first time. If you have any questions or comments, put it down. I'm in the middle of work, but I'll try to take a screenshot so that I can come back to your questions and review them and maybe send you a message, or you can just send me a DM if I'm not able to respond to your messages now. So we all know that nobody will miss STEMI. No one will miss an ST elevation when the ST elevation is maybe 5 millimeter away from the J junction, from the J point. Most doctors are not going to miss an obvious STEMI. Most people will catch it. But the ECGs that kill patients are usually the subtle ones, the ones that don't meet the STEMI criteria, all the ones where you print out the ECG and the ECG says non-specific ST elevation or non-specific ST or T wave changes. Those are the tricky ones, because now it's up to you as the medic to decide, is this ECG dangerous or is this ECG not dangerous? Now, I wanted to talk about 5 ECG patterns that can kill patients while you're busy looking for an ST elevation MI. I believe there's no medical person on here that will not recognize a STEMI. And if you learn nothing else, I want you to know that sometimes you're not treating, in fact, it's not sometimes, all the time, focus on the patient. The ECG is a tool to help you, but the ECG is not what you will diagnose. You can have a completely normal ECG, but you have a patient that has a central crushing pain. You still need to do something about it. You still need to ask for blood. You still need to give aspirin or follow the protocol for your hospital. Let me know if you have any comments or if you have any questions while I go through this. So if a patient, I want to ask you a question. If a patient arrives with crushing chest pain and by the time you see them, they are pain-free, they are comfortable, they are talking normally, and, would you still go ahead and do the ECG? Would you, the chest pain has gone away. Would you still go ahead and do an ECG? I want to wait for a few seconds to see if anybody's going to answer that. Well, I think I would still go ahead and arrange an ECG, right? Especially in the emergency department. Thank you, Carla. Yes. Even if I was in the GP or family care, I will still ask for an urgent ECG. So let's say you do this ECG for sure. Thank you, MedNerd. Thank you, TW. Let's say you do this ECG and it shows deep symmetrical T wave inversions in your V2, V3, a little bit in your V1. And you see this deep symmetrical T wave inversion. There's no ST elevation or minimal ST elevation, maybe just one small box. What are you thinking? What do you think might be going on in this patient? Any answers? Your patient is fine. They've had chest pain. The chest pain has come down. They are eager to leave you, but your ECG shows deep symmetrical T wave inversions in your V2, V3, maybe a little in your V1, maybe ST elevation of just minimal ST elevation of maybe just half a box. What are you going to do? What are you still going to do? Or what is your diagnosis? What are you thinking about? Anyone? Does anyone want to guess the answer? No answer is silly. Let's just engage. Okay, I would think of Wellens here, right? Wellens, because you're thinking of critical proximal left anterior descending artery stenosis. The artery may not be fully occluded, and that is why you don't have your classical ST elevation. But it's a sign that the process is ongoing, and the ECG is warning you. Thank you, Wellens type B. Thank you for being specific. Deep symmetrical T wave inversions is Wellens type B. Wellens type A is biphasic T waves, right? So The ECG is warning you that there's a large anterior ST elevation coming. It's like a warning sign. I used to say if the Winters is telling you that winter is here, Wellings is warning. Wellings is warning. It's warning you that a full occlusion is imminent. That is not the kind of patient you send home. You go ahead, you do your troponins. Even troponins may not be very elevated, but you want to keep them at least for a while for monitoring, for assessments, for more checks. You can invite the cardiologist to see, but that is you will most likely want to admit them for observation and monitoring, because that's a critical impending LAD stenosis ongoing. So I want to share another one with you, right? And in that case, please do your onjet angiography as well, because it will tell you, it will show some level of occlusion. Sometimes you have a 60%, 70%, 80% occlusion. Now, let's say this patient has ongoing chest pain, right? Because that's the mistake. Sometimes there is an ECG and it's telling you this patient still has chest pain. Welling syndrome will not classically present with ongoing chest pain. In Welling syndrome, the chest pain has resolved. Thank you. Activate early cath, critical LAD disease. Thank you, Zane. So, but let's say in another situation, you have upsloping ST depression. Now, there are three clinchers here. Three clinchers I want you to take note of in this ECG. One is you have upsloping ST depression in your V1 to V6. And two, you have tall symmetric hyperacute T waves. And then number three clincher is you have ST elevation in AVR. What are you thinking about? Three things: ST elevation in AVR, upsloping ST depression, and then hyperacute looking T waves, tall symmetrical. What is going through your mind? Any answers? Any quick answers? Because I'm using my lunch break. I might be leaving you soon. I just want to know. De Winters. Zane, thank you very much for that. In De Winters, the classical De Winters you get upsloping ST depression in V1 to V6. You will get ST elevation in AVR most of the time, and you will get your hyperacute T waves. Those are your three clinchers for De Winters, right? Now, the management of De Winters is obviously you activate the cath lab, urgent reperfusion, and you have to treat like an ACS, acute coronary syndrome. If Wellings, just remember, if Wellings predicts it, if Wellings is the warning, De Winters is the storm. Now, I want to go through another situation with you. This is the third ECG case. I'm going to give you four clinchers for this ECG. Then you tell me what is going on here. Patient has chest pain, right? And you see ST depression in V1 to V3. But there are tall R waves in V1 to V3, and there are upright T waves anteriorly. So what you're seeing here is you're seeing ST depression in V1 to V3, tall R waves in V1 to V3, and upright T waves in the precordial leads. Then what are you thinking about? In some cases, let me even add one more clincher. In the fourth clincher is that in your 2, 3, and AVF, you have ST elevation. What is that scenario telling you? Any clinchers? So there's one thing I want you to think about. Whenever you have ST depression, right, in V1 to V3, out of all the differentials you have, always consider the possibility of posterior MI. A patient has chest pain and has ST depression if someone asks what do the different waves mean, okay, there's a post I made on the different waves. I'll see if I can send that to you. But basically, whenever you see ST depression in your V1 to V3, and especially when you're seeing tall R waves, because that's poor R wave progression, right? Poor R wave progression is when you're seeing the R wave not increasing in amplitude from your V1 to V6. Instead, you're seeing R waves getting taller and taller. That should alert you. And when I mentioned ST elevation in 2, 3 AVF, that shows that there's a concurrent inferior STEMI going on, because in many cases posterior MIs will go on in tandem with inferior MIs. You will have both scenarios in a single case, right? Now, that being said, like I said, a patient has chest pain, ST depression in anterior leads. Please think of posterior MI. Make sure you do troponins. Make sure that you're thinking of that. Now, let's assume that the only elevation you have, the only ST elevation you have is in AVR, and then you have widespread ST depression. What should be going through your mind? Does anyone have any answers? You get an ECG, patient has chest pain, right? But AVR, let's assume that you've been able to do your ECG checks, you know how to zone out your ECG in the 5 zones. What are you looking at? What are you thinking of if there's only isolated ST elevation in AVR and ST depression in the other leads? What is going through your mind? I'll give you a few seconds to answer that. Any takers? Okay, so if you ever have ST elevation in AVR with widespread ST depression, please think about one of 4 things. The first thing you should think about is global subendocardial ischemia. This is just telling you that there's widespread ischemia in all of the subendocardial tissue. Then you should also be thinking of left main disease, severe proximal LAD disease. You should be thinking of triple vessel disease. I have my appointment for 3 p.m. so I will be leaving soon, and that's why I'm quite in a hurry. But please feel free to drop your answers as whenever I ask a question. So whenever you see isolated ST elevation in AVL, please be worried. Please be very scared, especially in a symptomatic patient, likely triple vessel disease. Thank you, Zane. Thank you as always. So hyperkalemia is the other thing I want to talk about. We all should be aware of hyperkalemia. I've seen many cases where I don't have the blood test yet, but I've seen an ECG, and this ECG is showing your classical tall, narrow 10 T waves. We all should know that. But sometimes what you have is PR prolongation. Sometimes what you have is loss of P waves or flattening P waves. If you're seeing sine waves on an ECG, then that is severe hyperkalemia, likely more than 6.5, likely above 7, right? And so the myocardium is becoming electrically unstable if you have severe hyperkalemia. Please give IV calcium gluconate. IV calcium gluconate is not to treat the hyperkalemia necessarily, but it's to stabilize the cardiac membrane. And then you now want to give your insulin or dextrose to shift the potassium, right? To shift the potassium. And if some people will try nebulized salbutamol. If the potassium is obviously very high, then you want to think dialysis, you want to think potassium binders. I hope this has been helpful to you. If there are any questions, please ask. Otherwise, I will go and see my patients now. Any questions? Any areas of concerns? So thank you for joining. Please feel free. I will try to attend to my DMs, but send me an email if you want a faster response, because sometimes messages get lost in the DMs. Please feel free to join the course, join our private groups of our one-on-one classes. I have people like you, people like me who are interested in ECGs. We discuss ECGs on a daily basis. Thank you so much. Today was 5 ECGs that you need to be worried about other than a STEMI. Thank you, Zane, for contributing. Thank you others for contributing. Do have a great day.